I've got Dr. Vaidya, who's going to speak to us about his landmark article on the anterior internal fixator. So, Dr. Vaidya, welcome.
Thank you.
So, tell us, how did you sort of go about developing the study, this product? How did you come upon this idea?
Well, at the time, I'd moved to the United States, and I had started to deal with some pretty big patients, bigger than what I was used to in Canada. And we used to put anterior fixators on people's pelvises, and they just didn't do the trick. And we had, a lot of people had done some preliminary work on the Hanover frame, and the guys from Toronto about increased stability with supraacetabular pins. And I had done a spine fellowship in Vancouver and a trauma fellowship, so I was pretty used to using pedicle screws. And I think the last thing, I had worked with a guy named Bob Meek, who's a pretty famous orthopedic surgeon, and he was trying to fix pelvises by putting a snake tool through the pelvic anterior column and all the way around the pelvis. He's actually got a product that is coming out that does that, or has already come out. And we were trying to find a way not to have the external fixator outside the skin, because these guys were so big. And I'd been onto a beach in Europe, and I saw all these guys wearing bikinis, and they were kind of big, and you could still see that the guys could wear bikinis. So I was kind of fascinated by the fact that there was an area that the bikini fit and the belly fit over. And so we thought we could find a place over the pelvis where there was an area that you could put a bar under the skin and not interfere with the underlying structures you consider stand. Okay. So we kind of came up with this idea, and we had a bunch of really big guys who were my scrub techs. I call them my offensive line, and they made them wear bikini bathing suits and belts, and we had them sit and stand and took pictures of them, and looked like there was a place that we could put a bar, and we call this the bikini area. I mean, thank God that these guys would actually do this for me. It was a little creepy, but they did it. And we then did an anatomic study with some cadavers, and figured there was an area that we could put this in. So we gave it a shot on someone really big that we had trouble with the X-Fix, and it turned out it was pretty good. So we use it quite a bit. So we use it for closing down the front in a B or C type pelvic fracture, and I think we've tried it in things like ramus fractures and in symphyseal fractures, and in saddle type fractures. The things that we've written a paper where we've shown that fixing the symphysis with a plate is an easy thing to do, and is probably a better reduction than an infix. But in a really big person, or someone with a bladder injury, urethral injury, we've used an infix in symphyseal injuries too, just to avoid having plates contact with the bladder or the urethra. And it sort of turned out okay.
Okay. So, you said type B and C injuries, maybe patients not amenable to Rami screws.
Well, I think Rami screws is a good option as well. I think one of the things that the infix can help you with is help you with a reduction, where the Rami screws you have to reduce it and then put it in the Rami screw. So we use Rami screws as well, a fair amount, and what we may do in a bigger person is we would use an infix, or because we think in our hands anyway, we're a little quicker about doing it. The bad thing is we have to take them out. So there is an advantage of putting internal fixation, and a Rami screw is a good option as an alternative.
Okay. Likewise, you mentioned some of the limitations being hemodynamically unstable patients, maybe patients that have an infection or any concerning skin in that region. But what are your limitations of, when would you not consider using this device?
Anytime where you're under stress or the patient's under stress and you may not be able to get the equipment, or it's a little more fidgety than putting on an X-Fix, I think you can't compromise the timing for patient care. So we often put on an X-Fix when we have to in an acute hemodynamic unstable patient, and we may replace it with an Infix later or Ramus screws. So I think you have to have a controlled environment, you have to have the equipment, and you have to be comfortable with the equipment to do this. And pretty much most trauma surgeons are pretty facile with an X-Fix. So, that's probably the go-to thing in a stressful situation.
Okay.
Chip Rout has shown that maybe just a binder, a sheet in the stressful situation is a great idea. We do that.
Pelvic ring instability are still left unanswered. This is kind of a very
Weight bearing after fixation. So the biggest problem, I think, with pelvic fixation is we still don't have a device for an unstable pelvis that allows you to weight bear right away. We've been becoming a little more aggressive with this, weight bearing on the uninjured side or the less injured side, allowing people to transfer, triangular fixation for very unstable sacrums that may actually allow you to weight bear, but we haven't seen papers where people are weight bearing right away. There's a nice paper from Tom Higgins that talks about weight bearing at 6 weeks instead of 3 months. And I think many pelvic surgeons are doing that, weight bearing more early than we used to. So I don't think we've solved the immediate weight bearing scenario like a femoral nail.